Welcome to This Explainer. Today, we're taking a close look at a deeply human problem, one that affects literally millions across the globe, but especially across the African continent. We're talking about the portability gap. I mean, imagine packing up your entire life, moving to a new city, maybe even a new country, and realizing that while all your belongings made the journey just fine, your medical history just vanished. It's a serious issue with real, potentially devastating consequences. So we're going to unpack exactly why this happens, and more importantly, how it's finally being solved. Okay, let's dive into this. What actually happens when a patient moves, but their medical record doesn't? Think about it for a second. In an era where we can seamlessly transfer our bank accounts, our emails, our whole digital life across borders in just seconds, healthcare is somehow still stuck in the past. When a record doesn't move, the patient is forced to start completely from scratch. And starting from zero in healthcare, well, it's not just inconvenient, it can be incredibly dangerous.
Section 1, the record that didn't follow, internal and cross-border migration. To truly grasp what we're dealing with here, we need to look at the real human impact when these systems just fail to connect. Let's meet Nadia. She's a 39-year-old regional sales manager, and she was transferred internally from Nairobi down to Mombasa, Kenya. Now, she moved her whole life seamlessly, but when she walked into a new clinic in Mombasa, her medical records from Nairobi hadn't arrived. 3 whole years of clinical history, a very carefully established hypertension baseline, 18 months of medication management, just gone. Her new doctor had to start from absolute zero. And then there's Kofi. He's a 52-year-old architect managing type 2 diabetes, and he splits his time across borders, jumping between Accra, Ghana, and London. Because of that, his records existed in 2 entirely separate, non-communicating systems. Since his London doctor literally couldn't see his Accra endocrinologist's notes, Kofi was prescribed 2 medications that created a highly dangerous drug interaction, an interaction that, would have been instantly flagged if his record had simply traveled with him.
Section 2. Capital costs versus human harm. The heavy price of starting from zero. Now, Nadia and Kofi's stories, they aren't just rare edge cases. They represent a massive, systemic failure happening every single day across a continent of 1.4 billion people, a place where migration and movement are accelerating so rapidly. And this failure comes with a staggering price tag. $300 to $500, that's the estimated capital cost of duplicate diagnostic testing for every avoidable repeat episode. This is driven entirely by the simple absence of portable records. Because the new doctor can't see the previous tests, they just have to run them all over again. And this brilliantly illustrates the dual nature of this crisis. On one hand, we've got these highly measurable capital costs, right? Hundreds of dollars per test, just draining out-of-pocket funds. To put that into perspective, in sub-Saharan Africa, out-of-pocket health expenditure accounts for a massive 36% of total health spending. So this heavy financial burden is falling directly on the shoulders of patients who are often the least able to afford it. But then on the other side of this equation, we have the unquantifiable human costs, the actual clinical harm that happens in that blind spot between what the old medical record knew and what the new clinician was actually told. It's Nadia losing her vital clinical baseline. It's Kofi facing those dangerous, totally unflagged drug interactions. The capital cost hurts, for sure, but the human cost, that's where the real harm lies. Section 3. Frameworks lacking technical enforcement. Great policies, no technical reality.
Now, you might be wondering, isn't there a law against this? Shouldn't patients just have the right to carry their own data? Well, the contradiction here is actually fascinating when we look at the gap between political intent and the reality on the ground. Impartially speaking, the policy landscape is pretty clear. The African Union's Continental Health Data Governance Framework actively endorses the portability of patient data across its member states. On top of that, 17 African countries right now have data protection legislation that clearly recognizes a patient's right to access and port their health data. But, and this is a massive but, there is absolutely zero technical enforcement mechanism to make this a reality at the actual point of care. Summits happen, grand endorsements are signed, but because the underlying infrastructure hasn't been mandated or funded, patients are still forced to start from zero every single time they walk into a new clinic.
Section 4. The health vault infrastructure, solving the patient connectivity gap. But here is where the story shifts, because where those mandates and frameworks fell short, a real structural technological solution has stepped right in to bridge this massive gap. Enter Afrofarm Health. They aren't just throwing together another healthcare app or some fragmented digital tool. No, they are building the core infrastructure that healthcare has been missing all along. Afrofarm Health operates as a full-stack, AI-powered healthcare grid. They basically realized that Africa didn't have a healthcare innovation problem. It actually had an infrastructure coordination problem. So they built a living system, essentially an operating system for healthcare delivery, to connect the grid exactly where governments just haven't.
Now, what's really interesting about this technology is how it completely secures the patient's journey from start to finish. The AfriFarm Health Vault is built on 4 incredibly robust technical pillars. First up, it is FHIR compliant. That stands for Fast Healthcare Interoperability Resources. Basically, it uses global standards so any verified system can actually read the record without getting stuck in some proprietary lock-in. Second, it uses blockchain verification. This makes every single record totally tamper-proof and permanently trustworthy. Third, it boasts HIPAA-aligned security with AS-256 encryption, which guarantees the patient is the one fully controlling who gets access to their data. And fourth, and this is absolutely crucial for the African context, it has offline capability. Because, let's be honest, a patient's health history shouldn't vanish just because the cell signal happens to be weak where they're standing.
Section 5. Securing the care grid, the Continental Health Passport.
Let's move on and see how this builds into real-world mobility. The Health Vault secures the record internally, sure, but what happens when you physically cross a border, exactly like Kofi did? Well, the Continental Health Passport acts as a QR-enabled Pan-African health identity. We're talking travel-ready health profiles, vaccination records, and incredibly seamless cross-border doctor-to-doctor continuity. So instead of Kofi lugging around a thick folder of photocopies from Accra to London, papers that his new GP probably only half trusts and literally cannot verify, he just carries a secure QR code. His London GP scans it, and boom, everything is right there. The drug history, the endocrinologist's notes, the verified warnings, the whole shebang. That dangerous drug interaction, it gets flagged immediately by AfriFarm's AI, Dr. Cheerful, way before the prescription ever leaves the consultation room.
So the crucial takeaway here is this. The contradiction really is the argument. The laws protecting patient data, they already exist. And now, the infrastructure to actually carry that data exists too. This is a real game changer for 1.4 billion people. By establishing true systemic interoperability, we aren't just saving out-of-pocket costs for redundant tests. We're actually protecting hospital capacity, we're improving early diagnosis, and we're generating massive long-term system savings. It's all about connecting what already exists into one unified, trusted, verified system. The patient moved. Now, so does the record. It's a really powerful statement, isn't it? Nadia no longer loses her clinical baseline. Kofi no longer faces those terrifying, dangerous drug interactions when he crosses borders. The infrastructure is finally here. So I want to leave you with this provocative thought. As this technology continues to prove itself, how quickly will this kind of decentralized, patient-controlled infrastructure just become the unshakable global standard for healthcare everywhere? Thank you so much for joining me on this explainer. Keep learning, keep questioning, and I'll see you next time.